Well, hello everyone. Nelly, Arthi, it's good to see you guys, and thanks for setting this up. This is a case, a young woman, 28-year-old, who came with the chief complaint of rapidly enlarging pelvic mass. This patient had 2 prior ultrasounds in 2016 and 2015, where in one, this mass was partially visualized and was described as adenomyosis, the other one as an atypical fibroid. So we have the MRI, and I think we have residents in the audience. So a sagittal T2 weighted image. Here's the midline of the uterus. You can see the cervical canal, external os, internal os, and then you have this mass, about 14 centimeter. So,
Kashi, we're seeing a screen with like your image down in the right lower quadrant. I don't know if you're sharing the right screen, but.
Hold on. New share.
Because I don't see the cervix. Okay, that's good.
Do you see it?
Yeah, looks like a big T2 bright.
Oh, yes. Correct. So again, a family history. The personal history was enlarging pelvic mass, and this is what we see: sagittal T2. Ignore the Tarlov cyst. Ignore the Nabatean cyst. So I saw one of Arthi's presentation, and I think at each step, Arthi asked for some crowd opinion. Probably we might want to look at this on another view. This is probably this is the most important image for this case, and for those who like fat sats, here is the fat saturated image. And no hemorrhage in this lesion. This is the T1 out of phase. So any thoughts?
Some sort of sarcoma?
Come again?
Some sort of sarcoma, either
some sort of sarcoma. Some sort of sarcoma, sure.
In.
Can you be more specific?
I mean, with this appearance, I probably would have gone with mixed Mullerian tumor thing.
All right.
Or some kind of myxoid tumor, given how T2 bright it is.
Okay. How about this picture? Would this help? Would this tell you anything? Like this little crescentric lobule kind of
invading the myometrium?
Yes. So there's now this. I'm going to give you the post-contrast images. There's nothing surprising there. The tumor itself didn't have any restricted diffusion, and this is the post-contrast study. And if you want the sub, here's the subs. So some parts do not enhance, some parts have low-grade enhancement, and the kind of the thicker septa have a bit of a higher enhancement. Probably it's easiest to see in the post-contrast that this is really not an endometrial lesion. It's a myometrium, just compressing the endometrium to the side. And I'm just going to say that this is the typical appearance of the rare low-grade endometrial stromal sarcoma. You can, let me just share another picture with you. Do you see this AJR article? And so this is one form, and if you see, it is these kind of invasive fronts of tumor that actually dissect the myometrium and in the end create an image like this, which is very similar to our case. And this is growth pathology. It looks like a brain. So the reason why I was emphasizing those peripheral lobulations is that fairly typical for this lesion. So that's a low-grade endometrial stromal sarcoma. It goes with gradual growth in the 4 or 5 years that we know the patient for. And in the fact, in the description of this tumor, they say it sometimes can be mistaken with atypical fibroids or adenomyosis or focal adenomyosis.
Cool, good case. We had a quick question.